Hi, I'm Sarah Loudon from Total Health Conferencing, and welcome to an edition of a virtual town hall. This week, we will be talking about prostate cancer in the time of COVID-19. Welcome to our program. As always, and as you've come to rely on, we will have a mix between patient advocacy leaders, medical experts from all over the country, industry participants, and then followed by a testimonial by a patient. And probably one of the most powerful segments of the programming is the live Q&A. So I ask that anyone who's joining us on the registered format, please feel free to put your questions in the Q&A section down below. And if you're joining us on Facebook Live, please feel free to put your questions in the chat, and we will be sure to try to address them with our various audiences, either during their segments or during the Q&A. So I'd like to just quickly go over who we have joining us today for this prostate cancer town hall. We will start with an interview with advocacy leaders, and we'll be joined by Bo Stubblefield-Tave, who's the executive director of Us Too, as well as a survivor. We have Patrice Brown, the vice president of patient programs and advocacy for Zero. And we have Howard Soul, executive vice president for the Prostate Cancer Foundation. We will then be joined by three medical leaders, Dr. William Kelly from Jefferson Health, Dr. David Quinn from the University of Southern California, and Dr. Vivek Narayan from the University of Pennsylvania. Then we will be joined by our industry partner for today, Pfizer. So Dr. Ian Webb will be talking with us about, not necessarily about specific drugs and products, but really about what Pfizer's doing in this time of COVID, both to help with vaccine development and to also help with patient programs. And then we will conclude the individual portion of the town hall with Chaz Rodgers. We're really excited to have Chaz. He's a patient on active treatment. He's got a lot to say. So I really look forward to hearing him. And then once again, we'll be joined by the entire panel where we'll take question and answers. So I'm gonna ask my team to bring up the advocacy leaders only so we can get started. While my team brings up Bo, Patrice, and Howard, I just want to wish everybody a really great Saturday, and I hope that what you get out of this town hall is meaningful, both for you, for anyone who you're providing care for, and just, you know, in general, in terms of information about prostate cancer, that these things you find important. So I have the pleasure of being joined by three really incredible people who are continuing to do very strong things in the advocacy world. So I'm going to start with just asking each one of you to tell me who you are, what your position is again, and a little bit about your organization. As we dive a little deeper throughout the 40 minutes we'll be together, I'll ask more specific information. So Bo, I'm going to start with you.
Great. So my name is Bo Stubblefield-Tave. I'm the executive director of Us Too International. Took that position in January. I'm also more than 11 years as a prostate cancer survivor, so I'm wearing both those hats. Us Too is an amazing organization. It's been around for 30 years. We have nothing to do with Me Too, if you hear that. Actually, the name came because a group of survivors got together and said, you know, we love what Why Me is doing for women and breast cancer as survivors. We need something like that. And so Us Too was saying, affected by prostate cancer, Us Too. So we really started with support groups, and that is still a foundation of what we do. We have over 200 around the country, but now in addition, we have phone lines, we have a variety of connections, specialized programs like for gay men and their partners. We have a special phone call for caregivers, for them to have a chance to speak. And I think one of the things that we really care deeply about is prostate cancer is a personal struggle, it's a family affair, and it's a community crisis. So when someone gets prostate cancer, many other people are affected, and we always try to keep that in mind as an organization. So I say we've been around for 30 years. We've done support groups. We really focus on three things: support, education, and advocacy. That's both advocacy in the political sense, but also advocacy in terms of helping patients advocate for themselves in the system. And we will always do those three things. Two things that we're doing that are new, and we can talk more about those later. You may know that Black men are twice as likely to die from prostate cancer as other groups. So we're looking at a community-focused program where we'll attempt to reduce that death gap. The other thing is we've been doing support groups and support services for a long time. We're going to do a formative evaluation to find out how we make them stronger, how we attract men who are not currently participating, and so on. So a formative evaluation of our core product there.
Thank you. Thank you. Patrice, can you tell us a little bit about Zero?
Sure, I'd be happy to. So Patrice Brown, I lead our patient programs and advocacy at Zero. Zero's been around for over 20 years. We were really founded to make sure that there are research funding dollars for prostate cancer. We really started out by making sure that the congressionally directed medical program that focuses on prostate cancer, the Prostate Cancer Research Program, receives funding every year. So we lobby Congress every year to make sure that there's funding. That funding level has increased each year. And so this year we're up to $110 million for prostate cancer through that program. But we've since expanded beyond that. And so what's really important to us is that while we are supporting research, we're also improving the lives of men and their families and making sure that they have the support that they need. We do that through a number of programs. Primarily, we have a case management program called 0360 that allows men and their loved ones to get individual support to understand what resources are available to them and navigate through that process. You'd be not surprised to know that medical costs are extremely high, and a lot of times people don't understand what resources are out there. So that program does help shepherd them through that process. But what we also do is we have support programs. So we have a mentor program that pairs a man one-on-one with someone else that's been through that journey. We have a caregiver support program that we just launched to help caregivers as well. But a lot of what we do also is to make sure that people are connected online. So we have an online support platform as well. So it's nice to hear that there's both in person through us too. There's also us online through Zero. And there's so much that happens among all of the advocacy groups. And I love the way that our programs can help across a number of different channels. But one of the other things that we do in terms of education is we have a run walk series in a number of locations across the country, over 40. And what we do there is to raise awareness about prostate cancer and ensure that not only those that are impacted, but those that could be impacted understand about testing and what needs to happen with that, so that they are prepared to catch prostate cancer early, because if it's caught early, then certainly it's more treatable than if it's caught later. And so we want to be right there front and center to make sure that we're helping men and their families.
Fantastic. Thank you, Patrice. We'll dive a little deeper to both us two and Zero as we go forward. And then Howard, would you please fill us in about the Prostate Cancer Foundation?
My pleasure, and thank you for convening this fine webinar today. The Prostate Cancer Foundation is actually the largest source of philanthropic funds to support prostate cancer research. We've been in business and operational since 1993 and have raised in excess of $850 million. I'm not going to talk about any but two of the major accomplishments for patients this morning. We funded foundational science that led to the development of enzalutamide and abiraterone, and also funded the knowledge that was required by industry to launch prostate cancer clinical trials for PARP inhibitors. And it was a really good week for PARP inhibitor FDA approvals, and we're very glad about that. When the entire Milken enterprise, as we call it, became aware in February that something in the world was wrong, and there was a pandemic likely coming, we pivoted all of our organizations in economics and biomedical research and science, most notably in public health, towards COVID-19. And the amazing thing is that part of the viral infection actually requires a protein on the surface of lung cells called TMPRSS2 that had been studied in prostate cancer for many years. So you have this universe of prostate cancer medical oncologists that are used to this protein, TMPRSS2. We understand it. And I'm happy to say that the first clinical trial, randomized clinical trial, and hopefully we can get back to that word randomized a little later, has been initiated in the Veterans Administration Hospital System network funded by PCF. This network is actually studying androgen deprivation therapy as a way to treat COVID-19. And beyond that, we count another 25 clinical trials that either are in the drawing board stages or will be activated soon to address issues related to this viral infection, not just for prostate cancer patients, but for all patients. And then finally, I'd like to draw attention to our patient guide, which you can find, and if I can point to it there, it's hard to do when you're backwards, but pcf.org is our website. We provide a definitive patient guide, which has been updated with physician-vetted information on how to deal with prostate cancer during periods of quarantine, during periods of pandemics. It's free for everybody. It can be downloaded from our website, and I strongly encourage anybody interested in this to reach out to our website and get a copy.
Yes, and as part of our follow-up for anyone who's registered or who, in the future requests, we will be providing that information as well, so that you don't have to look for it. We'll make sure that we send it over. So, I mean, Bo, Patrice, and Howard, I have spent the last probably 6 weeks doing these virtual town halls with all different tumor types. Each town hall, I get the opportunity to spend time with advocacy organizations like each one of yours that serve, a variety of patients in a variety of clinical settings with, a variety of menu that reaches them where they are. And I think, there's been two common themes among all advocacy organization communications. The common takeaways are, A, you're not alone. We still are here. We're, standing with you. We're still providing the same level of resources and support that we always were. It's just a different method of finding them and of distributing them and communicating about them. That's the number one takeaway. And the number two takeaway, and I heard a little bit of it from Bo, although I believe that both Patrice and Howard, you would agree, the patient as an individual is the most important person on their healthcare team. And the more empowered they can be with information, either provided by their advocacy organization, in their own research about their disease, or through one-on-one conversations with their medical teams, the more information they have and the more involved they are with their diagnosis, with their treatment, and with what they're to do, either in surveillance and follow-up, whatever that might look like, the better their outcomes. So I think that all of you will agree, and as I kind of dive a little bit deeper into each one of your organizations, we've spoken so much about COVID, and I know that it needs the attention, but I also think that people need to also kind of focus on normalcy. Whatever new normal is going to look like, this is the new world we're living in. And so I'm going to start with you, Bo. You know, one thing that really resonated with me is that Black men are twice as likely to die from prostate cancer than others. And that too is a common theme. Minorities and even people with economic disparity, which I know, contrary to some belief, don't always go hand in hand. Those are two subsets of a population that we seem to be failing in a lot of ways. So tell me how Us Too dives deeper for that population to try to reach them where they are with meaningful information.
Yes, that's actually one of the things that attracted me to Us Too was there was a commitment before I was recruited to addressing this issue, which is long-standing, as you say. It affects other conditions as well, but in prostate cancer, it's particularly stunning in the sense that Black men are 40 to 60% more likely to get prostate cancer, but twice as likely to die from prostate cancer. And what we've decided upon is what we're calling the Prostate Cancer Death Gap Project.
Mm.
So we're going to focus on one specific community, initially in the greater Chicago area, and do what we call community-based participatory research, or CBPR. What that basically means is we will work in partnership with that community to first identify what's causing the death gap in this community. So if we're in a community of Bronzeville in Chicago, the issue may not be the same as in Dorchester and Boston. We're going to look at what's unique in that community in partnership with the community. Then based on that diagnosis, we'll develop treatments, interventions that we can make, whether it's around changing access to care, whether it's providing new training, things to reduce stigma. There are lots of different things that could be impactful, but the community is going to help us both design those, but also put them into place. It's the third step. And then the critical fourth step will evaluate the impact. So it's a circle, it's a cycle. We assess, we develop interventions, we implement interventions, and we evaluate. I think one of the things that's really critical to us is we will be with that community, any other communities that we reach, for the long run. We're not going to eliminate this gap in a few weeks or even a few months, maybe not even in a few years. So the commitment is to do this work ongoing. And part of that is building capacity within the community so that when our funding may reduce, and we hope it's never going to go away, there are folks in the community still doing the work. And whether it's churches, whether it's community health centers, whether it's community-based organizations, the community really takes charge of this process. And by really evaluating and publishing, we hope it can be replicated through our work and through others.
Yeah, no, I think that that's so important. You know, all the different elements that you said, and you know, it's almost like the teach a man to fish concept, because you can't always be there. A, you can't always be there, and B, you have limited bandwidth for where else you can be. So if you can develop programs that can be replicated in other communities without an intense investment of manpower, time, resources, et cetera, then you're able to kind of reach more and more of the population. Patrice, along the same lines, you know, you were talking about Zero's case manager programs. I think this is probably one of the best program types that I hear in advocacy organizations, because it really does take it out of almost a population resource and make it an individual resource. How does that work? And then how, if you're a patient living with a new diagnosis of prostate cancer, or maybe just hearing about this now and you're, you know, midway, how do you get connected to this case manager program?
So one of the great things about this program, I always want to say this first, is that it's absolutely free. And the reason I like to put that out first is that when people then hear about the services that come alongside that, they're really surprised. But from the zero perspective, we want to make sure that we can support people no matter where they are, no matter what their circumstance, and just fill a need. So the 0360 program is very simple in that the person, it could be the patient, it could be their loved one, calls a number. So I'll give the number just because. It's 844-244-1309. 844-244-1309. Dial that number and they're going to get a case manager on the phone that's going to start with some very simple questions. So when were they diagnosed? What were they diagnosed for? And I will take a step back and say it's also for folks that are going to a screening. Like they have a question about the screening. What is that? Is it going to hurt? What are the components? So all of those things. So they call this number and someone will ask them a whole series of questions, not only to understand their life around prostate cancer and understand what questions they have, but then understand their life in totality. So for example, if someone is calling because they're having trouble affording their prescriptions, the case manager will look for resources to help them afford their prescriptions. But in the event, let's say for some reason they live in an area where there aren't resources specific to that prescription, the case manager, because they have an idea in totality of what's going on in that person's life, will say, there might be a program to help offset your mortgage cost. And with the savings from that, you can use that to pay for your prescription. So they're looking for savings across that person's life in totality, and then using those savings to pay for whatever they need. What's really, I think, kind of inspiring to see over these past few weeks, which have been really challenging for so many, is that there are so many more support programs there, so many more resources that are available. And so we're able to help patients more. We see on one case, there's an average of about 18 touches that a case manager makes on behalf of that patient or family. And so it really isn't just the patient calls and they get a question answered, they get a partner that is really looking to support them. And that person can call back. They can call back in 6 months. They can call back in 2 weeks if they have a different issue that arises. And so we deal with insurance issues, we deal with cost issues. We also deal with emotional support, which we know right now is so critical as folks are isolated, they're concerned about social distancing, all of those things. There's also support there. So I think the program has been successful because of its personal touch.
I think it's fantastic. I mean, I'm really proud of Zero for thinking so deeply about what patients need at this time, and really just at the time of treatment. You know, we're always talking about universal health care and, you know, all these patches and fixes to the system that we have right now, but it's very difficult to think about all the changes that might take place in the future, especially when you're being diagnosed today. So having partners, really, as you were talking, I was thinking building friendships, because, you know, that's really more of what it is. You're building friendships with someone who, you know, has the ability to kind of keep you connected to the things that you don't even know you're going to need. And they do it in such a way that helps you from that, you know, 360 point of view. I love it. I really do love it. You know, Howard, we talked a little bit on the prep call, and I want to ask you this because I'm a cancer biologist. I started my career in cancer in research, and now I'm in medical education, which really is just presenting findings from clinical research in organized ways that, you know, we hope to be practice changing. You really have a passion for research, and I normally wait to ask this question when we get with the medical leaders, but I'd love to hear your point of view on what COVID did to an already struggling system of clinical research, and what your hope is we learn so that we emerge stronger.
Sure. Well, I would say, first of all, I want to thank Ms. Brown for advocating for the Department of Defense Prostate Cancer Research Program, which is a hugely successful program that Dr. Quinn and I and many others in our community have helped them pick their science. But I would say the single largest impact on our research ecosystem due to the pandemic is the fact that the labs have been closed. And we have reached out to hundreds of scientists, especially the younger ones, that I would characterize them almost universally with one word, and that is resilience. So several of them actually, you can work in the lab if you're doing something on COVID-19 with very strict rules and regulations, who can go, how often, spacing, distancing, etc. But people from the prostate cancer research community really stepped up and have come up with ideas that are resulting in many clinical trials now for COVID-19. Can you imagine people doing cancer research, specifically prostate cancer research, pivoting their research, going back into the lab and figuring out what's going on in the lung with respect to a virus? And I'm not going to get into the science of the intersecting Venn diagrams between prostate cancer and this coronavirus infection, but they're there. And laboratories at the Cleveland Clinic, at the University of Michigan, and many, many others, UCLA, have all stepped up, have published non-peer-reviewed data with the proviso that this is just for people to consume. It may be right, it may be wrong, it's incomplete, blah, blah, blah. Here it is, and help us think through it. We had a webinar on one of these topics a couple of weeks ago, and 600 people came. It was amazing. And even at an hour and 15 minutes, there were still like 525 people on this webinar. So the interest is there. People are in survival mode. However, everyone is thinking about what they can do with their intellect, their skills, their hands, their laboratories, their clinics to do something for COVID-19 patients.
Mm-hmm. Mm-hmm.
Now, the underlying point is we all want to get back to cancer science. And there's nobody that would argue with that. But it's going to be a slow climb back. Some places already have. University of Texas, I know, in Dallas, Southwestern Research Institute in Dallas, they're starting to go back slowly, methodically. But we need to get back to cancer, because as coronavirus infections go down, and hopefully as a nation and a world, we will control this little beast that you can't see. Patients are still dying of cancer, and probably, during this pandemic, not receiving all the care they should be at the time when they need it. But we need to get back to that, and that's our goal.
Yes, absolutely. Bo, Howard was talking about information. People are looking for information. They crave, credible information. It's why organizations like the Prostate Cancer Foundation and us too, and Zero could, put out information or put out webinars and see such a groundswell of people. Do you agree that at this time, especially where we have so much in social media, there's so much misinformation flying around, things about the virus not being real or politicizing things? How do you advise patients that look to us to where to go to get information so that they really can be up to date and informed?
Absolutely. One thing I would say is you've got to know your source. So we at Us2, PCF, Zero, all of us go to root sources that are reliable. We're with the CDC, we're with the Mayo Clinic, Johns Hopkins, and so on. And we're also bringing information from our own resources. So one of the things that we did early on with COVID-19, Dr. Mark Moyet, who's one of our advisors, has been for some time, started a series specifically on COVID-19 and prostate cancer. So those are all on our website. You can go back and read them as well. So there's a new one, maybe one or two every week. PCF has a different series. All of us are addressing this issue one way or the other. And having been in healthcare since 1980, and I worked at Cook County Hospital, I have never seen a part of an industry that is so collaborative and committed to the patient and the family as the prostate cancer care community is. So all of us work together. You know, we were just on a webinar with PCF we jointly sponsored. They put out a piece on our support groups with our support services director, Terry Lukowski. As Patrice mentioned early on, I was at the Zero Summit this year, and many of our support group leaders, these are the volunteers who are the wind beneath our wings. We have 200 support groups. Each one of them has a volunteer leader, generally a survivor or a clinician themselves, who runs that group. And many of them, in addition to doing that work, are also advocates for Zero. So there's a lot of collaboration, but the key is go to a source that's trustworthy. If you have any doubts, leave it behind. There are many good sources. Avoid anything that you're not sure is real.
Yes, I think that's sage advice. So thank you for that. Patrice, along those same lines, you know, patients who are diagnosed or living with cancer already live with a sense of awareness of risks to daily life. You know, whether you are on active treatment and you have a compromised immune system, or whether you just kind of realize that life is more fragile than you thought it was pre-diagnosis. Tell the audience what Zero would recommend as people are facing a lot of issues with emotions at this time. What do you say to patients when they say, I'm feeling isolated, or I'm feeling scared, or I really don't know what I should be doing as the rest of the United States starts opening up in its own time? Tell the audience what you would say as patient programs and advocacy VP that could kind of settle some of those worries.
Yeah, what's interesting is, as Bo was saying, we engage with a lot of experts, and we want to make sure that we're giving out credible information because we know this is such a critical time. So we created a COVID-19 site where we host a lot of information in videos. And one of the videos that's actually going up relatively soon, I think early next week, is around mental health and COVID-19 as it relates to prostate cancer patients. One of the things that we learned through shooting that video is that really folks need to just think about what their own needs are and really think about what are the small things that they can do to give themselves comfort. So they can still go out for a walk. They can still pick up the phone and call a friend. You know, we all do these Zooms all the time, but it's about those small incremental steps, those small things that add up to the larger picture when it comes to not isolating oneself from the rest of the world. Because Sarah, it is very concerning right now for cancer patients in general, just thinking about what it could do to their health if they're exposed to this virus. So it's about how do they still maintain that connection? And part of what we do to help support that is the mentor program to connect men with other prostate cancer survivors and patients. We've seen an uptick in that program because folks are looking for that connection. But it's really about that balance between being healthy, staying safe, and finding those small incremental ways to still find connection. But when it comes to social distancing, one of the other things that we're seeing is that now folks are going back to the doctor in a way that they hadn't before. We were hearing about men that were afraid to go to treatments. And we've been having some conversations about how they can do that and still maintain their health. Because as Howard was saying, folks need to do that. They should not stop their treatments. They really need to maintain their treatment plan so that there is no way to slide back and have a more dire outcome. And so what we're really steadfast in doing is making sure that the education is there so that folks know how to take that next step and don't cause further harm to their health.
Wonderful. And Patrice, just shout out the website for people to go to for more information on Zero.
Sure, it's zerocancer.org/COVID-19.
Wonderful, wonderful. Bo, before I forget, shout out the Us Too website resource where people can go for information.
Very similar. Our website is us2.org, and there's a COVID-19 page, so you can do /COVID-19. I encourage folks to take a quick look at least across the website, because there are a lot of different resources, and see what makes sense for you. In particular, if you're looking at COVID-19, again, there are a series of ongoing articles from Mark Moyad, and they are really exceptional, very timely, a little funny, and very very real. His tagline is, "Of course I'm concerned, I'm also deeply optimistic."
Yes, what a wonderful thing to kind of frame how we should be feeling, concerned but deeply optimistic. I think that really describes kind of the human spirit when you're looking at, I think, all of you have mentioned that people are still so actively engaged, people are reaching out for connection, people are donating, people are still heavily involved in the activities. So Howard, we've got just a couple of minutes left in this segment, but don't go anywhere afterwards. But I do want to kind of touch on that. So let's say that I'm someone who's home right now. Maybe I was deeply engaged in advocacy partnership or activities before COVID-19. I was doing the runs. I was heavily engaged in, going to support groups, etc. How do you encourage patients now or people who are interested in advocacy now to remain involved while we get back to a normal?
Well, our foundation, as many others will do, are having virtual events. We have a big program with Major League Baseball every year called the Home Run Challenge. That's going to become a virtual event on Facebook. And, I would encourage everybody, it's going to be kind of fun. Something that people can do to be engaged. And as my colleagues from other organizations have already stated, our website is a source of great information, a definitive patient guide with a very recently physician-vetted section on COVID-19 as an appendix. It's all free, and I urge patients to take a look at that on pcf.org.
Wonderful, wonderful. Well, I thank you for spending this first segment with me. I know that we've got a lot of questions in the chat. We'll get back to those during the Q&A. People are still very engaged. People want to know how they can help. People want to know how they can be helped when they're in a situation where they're feeling vulnerable. And so I thank you on behalf of the patient, caregiver, medical education, and really the global community on staying the course, even though there are challenges that were both unforeseen and very difficult to navigate through. So I thank you for all the things that you're continuing to do. And I look forward to working with each one of your organizations again, as we continue to kind of push this information out as teams, as new teams of collaborators. So I'll ask my team to bring up the medical experts next. As I said, if the advocate leaders can stay on, answer any chats that are outstanding, Q&As that are outstanding, and we'll be back with you at the Q&A end. So as we're bringing up our medical expert panel, I want to say that, we do one of these town halls, sometimes two of them, every week, and we really have gotten overwhelming support in terms of viewership. I mean, thousands of people share these and really find value in them. And if you find value in them too, we ask you to share them They're available on our Facebook page, and we always offer them up to our advocacy partners as well as the medical institutions that we work with. So I'm joined now by Dr. William Kelly from Jefferson Health, Dr. David Quinn from University of Southern California, and Dr. Vivek Narayan from University of Pennsylvania. When I was looking at the lineup, I thought, how did we get two PA people here? But I'm so happy to have you both here because I've worked with you. I've worked with all three of you in medical education, and I know from sitting into your talks that this is going to be a really great session. So welcome, and I'm actually, rather than to spend a great deal of time having you introduce yourselves, what I really want to do with the first question is say, maybe can you introduce yourself and your perspective of where we are right now in the COVID-19 timeline, now that we're kind of getting a little bit back to figuring out how we open up and get back to like kind of the standard of care in being with patients. So Dr. Kelly, I'm going to start with you and ask you, where do you think we are in that time continuum? We've got you on mute, Doc.
There you go.
Common Zoom.
The mouth was moving, but we couldn't hear anything.
Yes. I should be used by Zoom by now, but I'm medical oncologist at Sidney Kimmel Cancer Center at Thomas Jefferson University. And again, as said, we in Philadelphia, we are coming down, we're going down the downslope of the COVID infection here. We're not open yet for all business, but we are starting to roll out and see patients again and continue to treat patients. Throughout the COVID crisis, we continue to treat patients. And, standard care didn't change, but what was very interesting is how we actually delivered care was different. And, I think that's a big take-home point we've learned is that we can still take care of patients safely and address issues we have to in new modes of delivery of care. We've used telehealth a lot. We were really early developers at Jefferson. We've been using telehealth for over 5 years. And this was not, it was an easy transition for us. But I think the other thing that was actually very important, and the highest leaders in the institution felt it was imperative that we actually continue on clinical research for cancer patients, because sometimes that is the only treatment for patients. So all the way through the pandemic, we have kept clinical trials open for patients. And we found new ways to get those clinical trials done. And I think that's, and it's going to change how we do it in the future. And I think a lot of good is going to come out of this at the end.
Yes. Dr. Kelly, just as a follow-up to that, were you enrolling at the same kind of frequency, or did you find that we were focusing on maintenance of patients on trial?
Well, we continued rolling the early phase trials because that's sometimes the only hope for patients. Our accrual overall did go down. We are seeing now it's going back up, but we continued patients on investigational treatments all the way through.
Fantastic. I mean, really kudos to Jefferson for that, because I know that there have been a lot of large academic centers that just kind of had to put a freeze on everything. So really, I mean, congratulations to that. Dr. Quinn, I'm going to ask you the same question, and I'm going to actually ask it to you by saying we had Hope Rugo from University of California, San Francisco on for the breast cancer town hall. And one of the things she was saying, on that same town hall, we had Hal Burstein from Farber in Boston. And it was so interesting to see how California experienced COVID-19 very differently than Boston. And even San Francisco experienced it very differently than other areas in California. So maybe I'll ask you to speak to, how at USC you experienced COVID-19 and then what that meant for care.
So, yeah, in the second week of February, we prepared for COVID surge. we'd seen what had happened in Wuhan and Milan and Madrid was starting. And so we prepared to go to level 4, which meant that everything stopped. We had martial law. Fortunately, we haven't got there. And we've got to level 2. We've all been retrained. And I work at 2 facilities. Most of my work is done at the USC Norris Comprehensive Cancer Center and the related hospitals. And then just 500 yards from us is the USC, the Los Angeles County USC Medical Center, different population and also different exposure because the county was going to be in the way of all comers through their emergency room. We were somewhat less exposed in our other systems, but nonetheless, our process very much the same. So trials, at the county, they wanted to stop everything, all trials, take everyone off. And we had significant pushback and we said, look, we cannot stop therapy on these patients that have ongoing treatment. And so we've been able to continue therapy, which where stopping would have been dangerous. We have stopped now and we're in just our 4th week of not putting new patients on trials, and that's now up for discussion only at the county hospital. We've continued to accrue at USC Norris. Accrual has been down about 30%, but last week came up, and if we compare with the same week last year, we're 50% up. So there's a kind of rebound, and I think that reflects what we're seeing in clinical activity, where we went quiet, dark, whatever you want to call it, for probably about 6-7 weeks, switched to a large preponderance of telemedicine where we could, and also cancelled what was potentially electable or postponable imaging studies restaging at some cost. All of our screening stopped for a month, which is a great concern. And now those patients are back. They need to be screened if they're being screened for cancer and also other things. We've got a flood of things. And I was just discussing with Kevin Kelly in the kind of chat area that we're now really busy. I have a list of new patients that we need to see that's longer than almost any time in my 20 years at USC. Part of the issue is that in the community in Los Angeles, some of the community oncologists are limiting the new patients they see, and patients particularly that are complex. Sometimes they will send them straight to the big centers like USC and UCLA and what have you. And so we're now seeing that pattern. And then I guess the other thing that's important for us is that oncology, whether it's prostate cancer or anything else, is a team sport. Yeah. On the kind of provider side, the physician side, the mid-levels, and we're distancing. We're not having direct meetings. We're doing all of this sort of stuff, and that's actually difficult. People talk about depression and things, but I can remember growing up in Australia, the solo general practitioner 500 miles from anyone else looking after their community, being the highest risk for various things, depression, suicide, whatever the barometer is. So we're looking at trying to also look after the treaters, as it were. And our patients are extenuatingly supportive, I have to say.
Yeah, I did a inspired series. I feel like my whole life is now in front of Zoom. I'm interviewing everybody. I'm doing all these things, which in a way is wonderful, but in another way is very taxing. And we talked about this too in the setup, that all of us are so much more engaged in this screen time that on top of everything else. But when I was talking to her, she's a psychologist from the University of Miami. And we were talking about, mental health during COVID, and she was saying that for providers, there's something called compassion fatigue. And, you get to the point where it's like, you're not only caring for your patient, but you're caring for yourself on behalf of your family. You're balancing all of these changes in the professional world, but you don't have that same level of, you know, team camaraderie because you're disconnected. Everybody's working in isolation or, you know, unlimited skeleton crews. So I definitely feel for you. And at the same time, I also see the way patients are, you know, we get tweets and Facebook pictures and all these things of the way patients have worked together to give masks or little tokens of love that replace, you know, those, or try to replace those hugs and those physical touches. So again, I think it really does speak to the human spirit when you see people who are traditionally in, you know, the provider receiver mode now building friendships because we're all having this shared experience. Vivek, I would like to talk with you about Philadelphia a little bit differently. So, you know, we think about these really concentrated areas where it's like very city-based and you have different concerns for patients than, let's say, even where I am in South Florida, where, you know, everybody gets in a car to do everything. We don't have really any kind of public transportation or anything like that. As patients kind of come out, you know, David was talking about his patient list being longer than ever in his career. As patients come out and feel more comfortable getting back to clinic, how are you advising, you know, Philadelphians or even those that come from New Jersey and other places to come in and see you? How are you advising them to manage this kind of get back to normal mode as you open back your practice?
Yeah, so, you know, as Dr. Kelly and Dr. Quinn already talked about, this COVID-19 has had such a dramatic impact on our care delivery. And so we've had to really adapt rapidly. And it's not just things like telemedicine, but also rethinking how we can shift cancer care delivery outside of our main flagship institution, as you say, in a large urban center. And so we're taking a variety of different approaches as we sort of start this resurgence and patients hopefully start feeling more comfortable coming back to clinical care. So one thing has been that we're rethinking how we can actually shift cancer care delivery into a patient's home, because even though some of the social distancing restrictions are now being lifted, you know, we all still recognize that there's still a very important aspect of trying to limit the number of patients that are coming into Center City, Philadelphia. And so in prostate cancer, we are still actually having nurses go out to patients' home where they live to actually deliver a lot of the prostate cancer care in the comfort of their own home. So for example, all of the 3-month or 6-month androgen deprivation therapy injections that patients oftentimes receive as part of their prostate cancer care, we actually have nurses who go out to the home, obtain labs, including a PSA, and administer the injection in the patient's home, so therefore obviating a need to travel into Philadelphia. We're doing the same thing with bone supportive medications as well, so minimizing a need to travel to a clinical setting. And then one of the advantages of being in a large health system is certainly having satellite institutions at the various locations, whether it's South Jersey or the Philadelphia suburbs or areas around the community where patients can minimize the amount of distance they have to travel to receive their cancer care, and then can still communicate with their physicians through a telemedicine encounter. So even though these social restrictions are being lifted, I think we're very cognizant of the fact that we have to do this very gradually and still maintain these novel care delivery methods for at least the near future.
Mm-hmm. And Dr. Kelly, as Dr. Narayan was talking about, delivering care differently, I know that, through past town halls, one of the overarching questions we get from patients especially since they can kind of ask these questions, I don't want to say anonymously, but not directly to their own physicians. One of the most common questions we get is our care being compromised in any way because we have to do it differently? So I'd like you to speak to that.
I don't think so. I think it's actually being improved a little bit. I think that as we discussed before, I think Vivek and David both said is that we're changing how we deliver care at this time. I think that at the end, it's going to be actually better care because, one of the things that we also found is that we have to have more frequent touches with the patient, all right? And that's what we're finding too, is in between visits, we're actually reaching out to them. And we pick up a lot there. And I think that, we're having more frequent touches. We're using different modes of communicating with patients. They're actually, what I find, even when I go into telehealth, they love to talk. They're talking more. So, they're opening up a little more than I actually see them when they're in the office, which is actually very interesting. When you do telehealth, you get a glimpse inside their home life too. So you get a little different perspective than you don't when they're just coming in your office itself. So I think, it's going to be a combination of things that go forward. And I think that, we are delivering good care. I think we will get back up to our regular rate of clinical trial accrual, which is critically important for prostate cancer patients. And we're going to find ways to decentralize clinical trials to make it more easier for patients and also be able to treat patients in a wider distribution.
Yeah. No, I think that that's great. And, it's so funny because, again, I get to hear all the different perspectives, how you were saying it. You get to see kind of into the patient's home. I've had so many patients that say, we got to meet, doctor's 6-year-old son, or we got to see, what their living room looks like. And so I think patients too are feeling that deeper connection as we develop these new ways to communicate, and just kind of peering in, if you have like a home office day where you're doing your telemedical visits. So it is going both ways. Dr. Quinn, as we started this virtual town hall, we were talking to the advocacy organizations, and they were really focused on kind of delivering information to people of either minority populations or, economically disparate populations. Do you find that there are challenges, we kind of take for granted that everybody has stable internet connections and smartphones and, have the ability to have a family member, if they're of older age, be in the house to help them set up, the telemedical visit. Do you find that there are challenges with those populations that maybe we've got to kind of develop some patches to fix so that we can deliver care the same way?
Absolutely. So Los Angeles is unique in several respects. Los Angeles County, population roughly 10 million people, the most ethnically diverse county in the United States. In addition, the biggest spectrum of socioeconomic in terms of distribution. So most places have a bell curve somewhere in the middle. Ours is relatively flat. So we have a lot of people from different backgrounds that have linguistic and cultural challenges connecting. We have a disproportionate number of people that are in the lower two socioeconomic groups. We also have people that are in the higher ones. And we also have challenges of people that have not been able to move with technology as they've aged. So the kind of geriatric challenge, as it were, is a little bit different. So the access resources are quite interesting. The public school system here, LA Unified, it's estimated that close to 50% of children don't have access to electronic aids to learn. And we have a similar challenge with that. Now, it's interesting because most of the people have some sort of smartphone that we can use. And I think that when we first geared up telemedicine, for example, the two challenges that we noticed was that the technology, wherever they were, albeit old or new, didn't link up. And the other issue was trying to get an interpreter in, and that's been fixed. We have very good video and interpreter services that help. We dial them in, but you're managing a whole set of different things. So you've got someone that where they may or may not have the assistance of someone at home. Their primary language, which is most often for us Spanish, actually even more often than English, is well dealt with by interpreter. But you then want to show them their results. And so you're dealing with a multi-platform challenge that you've really got to be up for. So there are issues there. We've been able to help some people, and we've had help from the technology companies that you wouldn't believe. And I could, Apple, Samsung, Google, the Facebook folks have helped with certain platforms. And we're lucky because a lot of these people are centered in California. And I guess we've got to look at it. Someone said to me, you've got to be cynical because they're tapping a market that they weren't getting to before COVID-19. And I guess, yes, but we're connecting people in a way. And the learning curve for the patients is sometimes quite rapid. The bigger challenge is in the older patients. They're often isolating now. And if they're having technology issues, just working with them. And we have a whole, we've actually doubled our IT staff to deal with this. And the irony is that some of them are very happy to drive to USC, which is in East Los Angeles, and usually not the easiest to get to because the traffic here is dreadful. But they're now happy to drive in because they know they'll get care. And it actually takes them somewhere between 30 and 50% of the time to drive. Of course, the problem is that when around LA, people used to drive badly at 70 miles an hour. Now they drive badly at 95 miles an hour. And if you're an older person who doesn't do the freeways well, then that's a challenge. So from that perspective, yeah, there are a lot of challenges and we're looking at solving them. There were several things that came in with our transition to Obamacare that we have not adequately accessed in California. And there was distinct technology help, which a lot of us use to help our hospitals get up to speed on electronic medical records and that sort of thing. We didn't enact the patient side of this. We did somewhat, but we're now enacting some of those funds that have been sitting there. And we thought they were going to be taken away by the federal government, but in actual fact, with the last support package, we're encouraged to use them. And we've been able to use them retrospectively. So I think there's some resources there. We're doing better. We're still not reaching people. And there are people that just need to come in and see us either because they can't cope with the connection or because a clinician needs to actually physically look at them. And we're seeing that. The people who are admitted to hospital now are much higher acuity than we had before. Sometimes it's with COVID-19. We know how to deal with that and screen and do all that. But most often it's actually them sitting at home and maybe waiting a bit long. And between the touch points that Kevin Kelly was talking about, they can get sick and they don't want to bother us, which is interesting. And so that's a challenge for communication. And we switched to, our attending faculty switched to covering everyone after hours. We were being helped by our fellows and residents in some parts of the week. When the patients found out, they didn't want to call us at 2 o'clock in the morning. So you get a call at 6:30 and I say, you've been in agony for 5 hours. Well, why didn't you call me? And then they get upset that I'm upset. And I say, no, we just need to get you to somewhere where you can be looked after. And part of the reopening process is trying to make sure that we're there as the resource. And that's a challenge for each of us that run the different facilities.
Yep. No, I mean, I think, it's not unique, even though LA may represent such a wide disparity, again, here in South Florida, we've got a large Haitian population, a huge Spanish population, African American. I mean, it's just so diverse, and the levels of not just capability from a tech perspective, but from a cultural perspective. You find that there's no standard. And so, I hope Howard, Patrice, and Bo are listening, because this is definitely areas where patient advocacy organizations can partner together with medical teams to try to reach people where they are. Dr. Narayan, I have a big question for you. I mean, this is going to be a big one. So our American Society for Clinical Oncology meeting is coming up this weekend. And I want, maybe, this is the big part of the question, maybe you can give us two, in patient-friendly terms, two things you're really looking forward to knowing more about from this big meeting that really level sets every year what we can look forward to in practice-changing information. So what is exciting you about what's coming down the pike from the ASCO meeting this coming weekend?
Yeah, so I think we're all really excited for ASCO, but it's going to be an ASCO unlike any other in that completely virtual format. And but I think the content is still going to be, typical of ASCO. And I think the timing is certainly, coinciding with this across the nation idea of reopening and resurgence, and how do we get patients back to cancer care. And I think there's going to be some special sessions on, how COVID-19 is impacting cancer care, and specifically, in the various different tumor types. How can we think about potential overlap between the toxicities of therapy and COVID-19, and how we need to think about bringing those patients back into care. In terms of prostate cancer, I'm really, they've posted the abstracts now. I'm really looking forward to some of the upcoming data, and really thought about how we can implement PSMA imaging, because there's going to be some new data coming out from some validation trials about PSMA imaging in various clinical contexts in prostate cancer. And so I think that'll be something to stay tuned to next week.
Yes, and for all the patients and caregivers listening, ASCO, our American Society of Clinical Oncology meeting, it's a gathering of tens of thousands of oncologists that come from all around the world. It's not just oncologists, it's oncologists, hematologists, surgeons, radiation oncologists, patient advocates, scientists, just everyone getting together in the largest conference center in the United States, McCormick in Chicago. I mean, there are things like competitions of who can log the most steps between the different sessions, because it is so big, and it's like you're going from one. It's the Disneyland of cancer development. And what I love about what Dr. Narayan said is that this year we're not, as a cancer community, we're not simply looking for what are the updates in our own kind of fields of study, but we're looking at how has COVID-19 affected cancer care globally, and then what can we do specifically for patients, in a data-tested arena, and not just anecdotal information from all around. So I really encourage as many patients as possible either to talk with your advocacy organizations. They'll always list in great detail information that comes down from the scientific community, or get onto ASCO.org. And I know ASCO has a lot of patient-friendly resources as well. It may take a little bit of time for them to translate the podium presentations to patient language, but certainly look there, because that is an area of incredibly reliable information, especially in the cancer field. Dr. Kelly, as we round out, actually, we've got probably room for two more answers. So, I'm really always encouraged to hear that the delivery of care is being innovated as we go along. So when you find an area where you are struggling to deliver what you once called standard of care in one way, organizations like Jefferson and others look to find solutions. What have you found the most challenging? I mean, even if it's something, emotional, seeing your patients, mostly through a screen, anything, what have you found most challenging about this time?
Well, I think David touched on a couple of them. Is that we talk about all the technology we use, but there are limitations to populations that you can actually use them. The elderly or the more mature patient population, I call it, they're not as technology savvy. So having them set up that or using it is a real challenge for them. And, again, is that the other thing I see with, when you see telehealth, you don't get that fifth sense you do when you see a patient. There's something about when patient walks in a room, you can see if they're doing well or not. You always don't get that when you over telehealth. And, I think that we're going to have to develop ways to actually better assess patients at home and really know when that patient has to come in. And that's one of the challenges we have there. The other challenges we have is the underserved populations. Dave talked about it a lot. We have one of the largest underserved populations in Philadelphia. They don't have the resources. They don't have a cellular phone service. They don't have, they're not even have appropriate nutrition. How do we actually provide them the resources they need to actually even get cancer care? We've looked at ways of transportation. We've had a lot of generous people come up and get phones for them so they can have communication telehealth. We've had drives to actually, the Philadelphia police actually delivers groceries to the underserved populations there. So there is a growing need that we have to recognize and remember is in the COVID era, those are the most vulnerable populations that will have health problems with COVID infection, not only with their cancer. So we have to focus on those who can't afford it, who don't have the technology to really get the care, and figure out ways to make sure they don't get lost in the system.
Yeah, no, I thank you for that. And again, I think that applies, not only in prostate cancer, but really across the board. I know that, medicine is as much of an art as it is a science, as it is a passion. And so many times I've heard from doctors, that the challenges are there. And a lot of those challenges are, the barrier to having that physical touch. Delivering bad news is very difficult to do through a screen because, you want to reach out and hold someone's hand. Or you don't want to leave them thinking that, this is the end. You want to encourage them the same way that maybe body language or energy would have done in a physical setting. And then certainly having the opportunity to see patients that otherwise couldn't get access to physicians, I know has been something that's been very, very difficult.
The other thing that has been very difficult for patients is when they come into the hospital, there's no visitation to them. So you can have patients who are dying in the hospital who have no family around.
Yes.
While you can do it over, give them telehealth or, video, it's not the same as having your family present there. And, again, is that, that's been one of the biggest struggles I've seen with patients when they can't come with their caregivers. They can't be with the patients can't be with their family during these very trying times. So this is the emotional toll that is actually growing, and we need to solve that.
Yeah, yeah. Dr. Quinn, I mean, with the same vein, and we've just got a couple minutes left, in the same vein as, what have been some of the challenges? What have been some of the wins? What have you seen that you're like, I'd really like this to stay because we're doing this the right way?
Good. So just before I answer that question, so our discussions have been about the challenges for the alpha and the omega of our oncology spectrum. So the alpha is the patients that are newly diagnosed, including prostate cancer patients where I am seeing bulky de novo metastatic prostate cancer patients, and I opened up, I think, 7 different additional slots in this past week to see them because they're coming in, and we've got this issue of the lack of screening now really coming home to roost, but just the delay in COVID, I think, has seen that. And then as Kevin mentioned and Vivek has alluded to, the people in hospital who are passing, and we're working on that. So what are the good things? I think that the expansion of telehealth is a major achievement. It was something we were meant to do when we implemented Obamacare. In California, it was slowed down by a lot of things, including the privacy laws. And all of a sudden, we got those privacy law issues solved within 5 days. I just would tip my hat to the governor, Gavin Newsom, for getting that fixed and pulled the various bodies in Sacramento into session and said, this is totally unacceptable. We're out of sync here. So that is not going to go away. I don't need to make people drive 4 hours each way to see me for everything, and I'd like to avoid that. And there are people that we're not reaching with high quality healthcare because of that. So I think that's a really good thing. And the other issue is malleability of being able to deliver research, and both Kevin and Vivek mentioned this, but we've now gone through a series of classes where we teach our staff and each other about how to go through a consenting process for a clinical trial and be successful on say Zoom or whatever you use. And also the rules for getting them to sign that consent and be truly informed. And I think that's actually taught us a lot because we have a very individual style of talking to people, and that face-to-face interaction for me doing a consent is really key. And then when I'll talk to the patient about the trial, and then I'll hand them to the research staff, who could be a research coordinator, CRA, research nurse, or in some cases we have research dietitians and physical therapists, occupational therapists, and they'll listen to me, particularly if I know them. This is the patient, but the link with whoever's going to be directly involved coordinating their care is actually key. And getting that across a Zoom is a really big challenge. And Kevin mentioned that the patients are talking more, they're asking more questions, they're really good questions. It also lets them often bring a family member into that conversation if they live a ways away. And so I think they're the two things. We're going to get better at delivering trials. We're going to stop people having to drive around California and Los Angeles, and there won't be an impediment to them getting to a tertiary quality center anymore in terms of that tyranny of distance.
Yeah, no, I think that too is echoed across tumor types, that access to clinical trials, first design of clinical trials will take into consideration, do we really need all of these interim visits and additional blood draws, et cetera? What are we really looking for? And then what will that access look like? If you're a patient if someone seeing you at University of Southern California and there's a trial open at the University of Pennsylvania, and you can get on the phone with Dr. Narayan and say, hey, listen, I think this patient might match. I do think that that's the direction we're moving in because we've been shown why not. So I really think that, this is one of the good things that have come out of COVID-19.
Just to make the point, our public networks, our cooperative groups, and our early clinical trials network through the what's called CTEP at the NCI, have facilitated a lot of those links in terms of being able to do trials relatively easily. And the FDA had written a white paper in January about trying to make trials from commercial entities, for pharma companies predominantly, but also some others, more available that discuss some of these points. And I'm looking forward to us getting back to that. In the prostate cancer research program of the Department of Defense that you've heard mentioned, of which I'm the chair of the integration panel this year, we're looking at that accessibility to trials because there are some people that we don't reach. We talked about ethnic disparities, but there are also rural disparities.
Yeah.
You know, you've got someone that lives a long way away. Try getting them on a trial, and we're looking to address that, as well as the communication that occurs back to the patients that are involved, that have been in those trials or that went through the consenting process and couldn't do it or wouldn't do it, to make sure that things are communicated to them about what happened with the research that was done and funded.
Yeah, no, very exciting things. And I think, you know, all the communities that are invested ultimately in patient care and outcomes need to kind of keep the pressure on this, because as we reopen and priorities start to shift, I think it could easily get lost in, you know, kind of the conversation of convenience. Well, that's really not what we should be focusing on, but it is, because without it, you know, we don't get the advances that we get. So I want to thank all three of you. I want you to stay with us, you know, answer some of the Q&A open in the chat. We're going to be moving on. I'm going to ask my team to bring up Dr. Ian Webb from Pfizer. And as we bring up Dr. Webb, you know, I always struggle with including kind of personal feelings in any of these town halls, but today I just feel like I will. You know, I'm a patient, immunocompromised. I've got an autoimmune disease. I'm looking at the reopening of COVID very differently than even, you know, let's say my brothers or good friends. One of the things that I'm very concerned, and it's not concerned in this, you know, crazy conspiracy way, but Dr. Webb, I know that you will be able to share with us some of this. One of the things I'm concerned with is the speed to which we're developing vaccines. I know, being a researcher, that we can do it quickly. But the fear, you know, just the mom in me and the one who says, well, can we safely do it quickly? So I know I've got a lot to cover with you in just the 10 minutes that we have, but this is on the minds of everyone. This is really the pinnacle of how the world gets back to business. We get a vaccine. And I know Pfizer is very engaged with vaccine development, as are many organizations in the pharmaceutical space. So maybe if we start with what you're doing for vaccine development, and perhaps you can ease mine and many other people's fears that swiftness in developing a vaccine does not mean compromise for safety.
Yeah, thank you. You know, certainly an excellent, really excellent question. So first of all, I'd just like to say good afternoon to everyone and say it's a pleasure to speak to you all today. As Sarah mentioned, my name is Dr. Ian Webb. I am the global medical lead at Pfizer for prostate cancer and biosimilars for Pfizer Oncology. So I oversee our global medical affairs organization in those areas. So, you know, the question about vaccines, I think, is a superb one. So, you know, we, as a company, signed an agreement to work with a German biotech named BioNTech to develop a novel coronavirus vaccine specific for the coronavirus that produces COVID-19. The company BioNTech is actually one we've been working with for several years now to produce a flu vaccine using the same technology. And this is new novel technology using mRNA as the main scientific platform for developing the vaccine. What I can say to you is that, as a company, we have really been focusing extensively on trying to meet the needs of COVID-19, and the vaccine is certainly part of that. And we actually have a 5-point plan developed for producing therapies as well as a vaccine for COVID-19, as well as a plan that we hope will prepare us as an industry to better respond to future global health crises. So the 5 points, first of them is that we're sharing tools and insights. So, this is a new way of working rather than sort of the siloed, each company doing its own thing approach, where we're sharing tools and insights and making them available on an open source platform to the broader scientific community in real time. We're marshaling our people, which include a wide array of people with different expertise. We have virologists, biologists, clinicians, and vaccine experts. And they're all focused solely on addressing this pandemic. We're going to apply our drug development expertise to support the most promising candidates that we may bring forward, as well as those that the smaller biotech companies may bring forward. So we're here to help other companies if they have needs that we can address. And then we're offering our manufacturing capabilities. So, in terms of getting the vaccine out quickly, we're preparing in advance to be able to manufacture the vaccine, even though we don't yet know that we have a vaccine that's ready to be manufactured on a large scale. But despite that, even if we have any excess manufacturing capabilities, we're going to offer that to others to potentially bring other COVID-19 vaccines or therapies forward to patients as soon as possible. And then thinking about the future, we're going to improve the future rapid response capabilities, we hope, by partnering with federal agencies such as CDC and NIH to build a cross-industry rapid response team. And so there are 3 key areas I think that are worth highlighting here in terms of things that we're doing. So I mentioned the collaboration agreement with BioNTech. And in terms of, being quick, what I would say is that we actually have 4 different vaccine candidates in one clinical trial at the moment, so that we can hopefully find one or maybe more than one that's worthwhile to take forward into later clinical trials. So as opposed to doing 4 trials, or we're doing 1 trial, and it'll be kind of like a pick the winner strategy. And we hope that'll bring the vaccine therapy forward as quickly as possible. We announced a couple of weeks ago that we started dosing in the United States, and dosing in Germany started a week before that, so those trials are well underway. I'd also say we have an investigational antiviral compound that we're working to get in the clinic, hopefully this summer. And then sort of in a broader framework, we're also augmenting our patient assistance program at this point in time. So just to say that in addition to the vaccine, and hopefully I've shared with you some of the key elements of what we're trying to do to bring that forward quickly, we do have a broader program where we're trying to help patients have access to new therapies as quickly as possible.
Absolutely. And, as we round out our time, we've got about 4 or 5 minutes left. I often say, especially when I'm kind of talking to industry leaders, industry medical leaders like yourself, there are various sizes of organizations that we get to engage with when we're doing either these town halls or working on, individual projects. Pfizer is a massive organization, and to see how quickly the teams got together to identify how could you pivot to not just, advance in cancer care and in the other areas of care that Pfizer is invested in, but now how could you pivot to really become a resource to the community in collaborations, in refocusing some of the partnerships that you had, like the partnership with this German company to develop vaccine candidates. it has really been nothing short of miraculous, because what I see is that everybody said, okay, we're no longer a pharmaceutical company competing in a space. We're a set of, brilliant physicians, scientists, salespeople, researchers, everybody that makes up the Pfizer organization and others. We're all in this new pandemic together. And so watching the way Pfizer and other companies have really rallied around that unified message that, in order for all of us to get back to business, all of us have to behave in ways that really hold each other up during this time. It leads me to my last question for you, Dr. Webb. This is a town hall specifically catered for prostate cancer in the time of COVID-19, and most of our audience are patients, although we do get a great deal of providers that listen to the repeat broadcasts. If you had one kind of takeaway message, one centralized message that you'd like to give the cancer community, what would that be? Oh, I've got you on mute, Doc.
More. Yeah, I think, the panelists today, I think, have made it quite clear, and I think it's no surprise to everyone that we're living in unprecedented times here. And, what I would say is that, I personally am incredibly impressed and inspired of the resilience that I've seen. The resilience of people living with cancer, their caregivers, their families, cancer survivors, the patient advocates, healthcare professionals, as well as the broader community, have all shown incredible resilience in these unprecedented and somewhat, frightening times that we're living in.
Yeah.
What I would say is that, now more than ever, we have to continue to work together. We have to support each other. We have to maintain our sense of closeness and act as one team to respond to this urgent public health challenge. And, I personally have seen that in my day-to-day work, working with my colleagues at Pfizer and working with colleagues beyond Pfizer in the industry and with healthcare professionals, patient advocacy groups that we talk with. I mean, everyone is really focused on these really challenging times. And I think it's so evident in today's program. And it's so wonderful to have a series like this.
Yes.
And, I remain incredibly hopeful that through our science, our expertise, and our collective efforts, that we're going to be successful.
Yes, I agree with you. I agree with you, Doc. And I think all of us, we have that hopeful optimism, as Bo said in the beginning. So I thank you for your time. I thank you for sharing what Pfizer is doing at this time. We're all rooting for you. Because, in rooting for you, we're really rooting for all of us kind of getting back to who we know and love, and those hugs between grandparents and grandkids, and being able to, worship in churches and synagogues and mosques together, and just all the things that make us uniquely human. So I really thank you for the work that you're doing, and we hold you up. Doc, don't go anywhere. I'm going to ask my team to bring up our patient for the day, but then we'll ask you to join us for the panel for Q&A afterwards. So as we get Chaz up on the screen, I hope that those who have been participating in the town hall till now really feel that you've been given, a good deal of information that covers a lot of different areas, what advocates are doing to help support you, what medical experts are continuing to commit to in order to provide you really great care, and a peek, which I don't think is really common, into what industry is doing, not just in cancer care, but in areas like vaccine development. And I was happy to be able to get my question out there, because I know that I'm not alone in thinking, this vaccine, while it's such a hopeful thing, there's still kind of levels of uncertainty and fear around taking something. So I was glad that Dr. Webb was able to give us some more information. Chaz, welcome to the program, and I'm so glad that you joined us. This is always my favorite part. I'm a newly diagnosed patient with an autoimmune disease, very different from cancer, but in a lot of ways very similar. I mean, it's, you know, a chronic management of a disease that has rapidly and significantly changed your life. And, you know, certainly I always say to people the day before my diagnosis, you know, this was how I felt, and the day after my diagnosis, this is how I felt. And it was almost like two different Sarahs. So yeah. I just want to ask you to share a little bit of your story. We've got such a short time. You know, I'm going to circle back around with all the patients from these town halls and do a patient town hall, because I think that's really where we're going to get into some of the nitty gritty. But if you could share with us a little bit about your journey, what's brought you here, and then we can go into some other questions.
So I'll do my best to keep this brief, because I know that time is always an issue with these types of forums. First of all, thank you for the opportunity, you know, to speak on such a large platform. Just a quick Reader's Digest about my life prior to pick up on your first point. Prior to being diagnosed as a prostate cancer patient, I was a full-time personal fitness trainer, so I was quite busy. My family had 3 kids at that time, under, I believe, the age of 10 at the time, and I have a wife that's in the healthcare industry. And so I was running a full-time personal training business in Orange County, California. She's working for a healthcare company. We got 3 little kids. We're busy. Yeah. And one of the things that I started doing for myself a long time back, during my time in the military, I'm a U.S. Navy veteran, was to get a physical. And so every single year, no matter what, talking to my clients about taking care of themselves, I practiced what I preach. I said, okay, you got to reach physical. Have you done that? No. Do this, do that, do that. And so I made sure I was doing the exact same thing. And about a year prior to my diagnosis, I started just asking myself some questions, because I did not know my actual history or health history from my father's side of my family. My father left our family when I was about 13 years of age. I didn't know much about the men on that side, their health history, nothing. My uncles on my mother's side of the family never went to the doctor. I don't know how they did this, but they never went to, that I was aware of. And so there was a lot of missing information for me as I got older. So on my 45th birthday, I decided when I go to this physical, I just hired an internist, because I was told by some of my clients, the one good benefit from being a personal trainer, you get to access a lot of different people from a lot of different backgrounds. Some very wealthy, some in the middle, some not as wealthy, but just working hard. And I've had the honor to work with a lot of different people from a lot of different backgrounds. So, and I take information from them, right? So I think the old Catholic adage is you tell everything to your priest, your hairstylist, and in my case, your personal trainer. Got a lot of tips, right? So I used some of that information, hired this internist. Turned out about probably a third of my clients were using the same guy. And we just had a really candid conversation about health and fitness. And he would talk to me about workouts and what my advice, but this is what came out of that discussion. What should I be doing for myself? And he says, dude, you're 190 pounds, you're under 10% body fat, you're crushing, you're good. I said, yeah, I hear you, doc, but I'm serious. I just want to know, you know, and if there's nothing there, cool. There's nothing there, and I'm going to go on my day, and I wouldn't be here today. So he decides, okay, fine, we'll do the test. So the first thing I found out was the DRE. I didn't know what that was. Learned all about that. I get my DRE. I get a phone call. My doctors don't call me. By the way, my doctors called me to ask me about what type of workout they should be doing or what they should eat because they're going to this big thing. Not, hey, by the way, you got a problem health-wise. And that's what started my journey. And so in 2013, on my 45th birthday, I was diagnosed with prostate cancer. Now, I didn't know what it was, had no idea what stage, what my Gleason score. I knew none of this lingo and none of this language. And anybody who's a patient out there or newly diagnosed, I want you to take this on board as one of my first little caveats. The second you hear something, start your research. Yeah. Because there were a lot of things I did not know about this cancer, especially as it relates to African-American men. Because we don't talk about it. Doctors don't really talk about it. They're not even forced to do what's called a PSA for you. It's in the recommendation, but it's clearly a recommendation. And it has a class D or now I think a class C rating. They don't have to bring it up. So if you don't ask, you don't know. And so that's the military in me, if you can't tell. That I got that from being in service. You know, I get orders. In the Navy, you get orders. You get those orders, you repeat those orders back to your commanding officer or your petty officer in charge or what have you. And I got really good at that. So I was a young senior in service, and I had some college time to learn. I repeat back the orders. So I talked to my doctor and I said, okay, you said I didn't have to do this, but you didn't say I couldn't. He's like, okay, final order test. That's literally how it happened. And then from there, I started finding out.
Back from your microphone. I don't know if anybody else is feeling that, but just adjust. If you can, go ahead.
So yeah, so that's what happened. So I asked the question, and then we started the process. So obviously the DRE is first. Then they ordered the blood test, which the PSA. I'm sure your listeners can research this, and we can talk about it. It's on the Zero Cancer website. But I got to tell you some stats that helped me kind of start navigating the first portion of this journey. And I wanted to read this because I did not want to get these wrong. Okay. 20,000 men, 191,000 men are diagnosed with prostate cancer. The rumor was it was an old white man's disease.
Yes, yes.
You're an old white guy. You're not, I was like, okay, well, guess what? That's wrong. Very wrong. And so, not good. There are 33,000 men who died from it.
Oh, I'm losing you again, Chaz.
You're losing me. I'm not sure why. Let me, can you hear me?
Yeah, I can hear you.
I'm going to turn my mic all the way up. So yeah, so the stat was 33,000 men will die from it. After decades of decline, prostate cancer deaths are on the rise. We're not sure why. I think that's being researched. In the last 2 years, we have seen an increase in 30,000 more men diagnosed with it. Now, I think it's because of kind of what I did for myself personally, was I actually went and found the information and asked questions, and doctors were having more of a conversation. So I don't really see that as a negative, that there are more diagnoses, because it doesn't mean that you're going to die from the cancer. It just means that you're aware of the signs of it. I think that's important, especially as a black man. I think it's more important for people have to make sure that they ask the question.
Yeah.
So they just have to. 1 in 9 men will be diagnosed with prostate cancer in their lifetime. But when I was first diagnosed, I was told, well, that's not going to kill you. That's not going to kill you. You may have it, that may not do anything to you. I was like, yeah, that may be true. But why don't I find out, right? And so what was really disturbing to me and how I got involved with Zero, to answer your question, was I was so upset and so disappointed about what I did not know. Especially, look, I'm not a healthcare professional, but I'm in the health and fitness industry.
Yes.
And I try to help people improve and help and their lives. And that's what I've been doing for 25 years. This was probably the single most disturbing statistic for me. It was African American men are at an increased risk of the disease. And 1 in 6 of us will be diagnosed with this cancer. Now, I didn't know that 7 years ago when I was diagnosed. Wasn't aware of it, never heard about it. And it was really shocking to me. And I was at a loss when I got that diagnosis. So the good news about this is that if caught early, prostate cancer has a 5-year survival rate of nearly 100%. Hi, that's me, right? But it took what I've done journey-wise to get to that point, to come on the other side of it. I got involved with Zero just quickly because I was looking for a way to impact people's lives, especially, men in general, but African American men especially, because we haven't been very good at having this kind of discussion. It doesn't matter your social economic background, by the way, whether you're the wealthy of us or, the least among us, it doesn't matter. This cancer knows no face, it knows no age, it just does what it's going to do. And as a matter of principle, how do you decide for yourself to approach that and handle it?
Chaz, I love so many things about what you said, because really what you're saying is exactly what I said to the advocacy groups that have been really the takeaway from all these town halls I've been doing, and was the takeaway for me in the autoimmune space. And I came to learn for so many patients like me if we don't start to become our own health advocates, we've already lost half the battle.
Yep.
So I really, you know, I'm going to ask my team to bring everybody back up, and as we get into the Q&A, you know, a huge part of your story is that you were so proactive, and even the part of your story where you know, purposefully sought out your background, your health background. I think for so many people, they don't take into consideration maybe their high risk because of their familial background, and so they're just not answering or asking the questions. Marry that to the fact that you look healthy, you feel healthy, you are healthy, you teach other people about health, and then you know, you're in the doctor's office, as you say, where he says, you know, Guy, you've got a problem. So you know, as we go through some of these Q&As that have just been really robust, Chaz, I'm going to ask you a few things, but let me go through some of these that have been kind of asked. So, you know, the doctors, this is when after patients are diagnosed, how do doctors make the decision to treat or not to treat? Dr. Narayan, we've got 15 minutes, so I'd like all of you guys to answer, all of you guys and lady, like me, Patrice, we're representing here, to answer briefly, but as comprehensively as possible. How do you make the decision to treat or not treat?
Yeah, so I assume that that attendee is asking that question in the context of COVID-19. And I think in that context, our approach has been to really balance three different factors in trying to make that decision about the urgency of treatment in the context of COVID. So factor one is really understanding what is the biology of the underlying disease. So what's the natural history of it? Factor two is trying to keep in mind the necessary social distancing aspects and prioritizing patients that you actually want to bring into the clinic center. And then factor three is just the natural patient anxiety and really physician anxiety that comes with potentially delaying a patient's care. And so when we try to balance those three things, it sort of varies depending on the clinical scenario. But you know, one of the nice things about prostate cancer is number one, that in the localized care setting, so when men have prostate cancer believed to be confined to just the prostate gland, in many cases, we often have the luxury of some time. And so, you know, I think sort of what we tell patients as a general rule of thumb, a potential delay on the order of 3 to 5 months before your, you know, hopefully curative intent treatment is unlikely in the vast majority of cases to dramatically affect a long-term outcome. Mm-hmm. And then in the sort of more advanced stage setting, one of the nice things about prostate cancer is that we have the luxury of a lot of different treatment options that can all be clinically acceptable in certain situations. And so when we have that kind of equipoise in our clinical decision-making, we can then choose what treatments we believe to be most opportune in terms of the context of COVID. So the therapies that may be less immunosuppressive. So foregoing chemotherapy instead of a potential hormonal agent when we otherwise feel that both options are equivalent in prostate cancer outcomes. And so that's just, you know, one example, but I think we sort of use those three factors and try to balance them as best we can in trying to decide the urgency of treatment and then what type of treatment we're going to pursue.
And Doc, is that typically a shared decision? Are you actively talking with your patients at that time saying, look, this is what I'm trying to balance? And are you hopeful that they will have kind of information back to you to say, okay, that's worth my risk, or, you know, can you explain more?
Yeah, absolutely. I mean, I think it's definitely a shared decision factor. You know, I think, you know, from the patient perspective, they obviously, you know, are trying to balance on their own end the priorities of their own cancer care, but also the very real potential risks of a COVID-19 infection. And I think, you know, one of the notable things is that a lot of the epidemiology of COVID-19 in terms of risk of severe disease, as well as prostate cancer epidemiology, there's a lot of overlap. You know, we've heard so much about, of course, older patients, male patients, patients with comorbid medical conditions like heart disease or other health issues. You know, there's a lot of overlap between those risk factors for severe COVID infection, but also just the the population of men we see oftentimes with prostate cancer. And so there's obviously a natural anxiety from the patient standpoint as well.
Yeah, no, I think that that's great. Thank you for that answer. Patrice, someone has asked, should we stay connected to advocacy groups even after treatment?
Oh, absolutely. Advocacy groups need patients and survivors to tell their stories. We need patients and survivors and caregivers, families, friends, everyone to create this collective set of information about how they were impacted by the disease and what survivorship looks like. I think survivorship is really important because so many folks focus on, okay, I'm in the fight right now, I'm struggling through this, I'm dealing with this treatment plan, but there's life on the other side of that, and patients need to hear that too. They need to know that there's a new sense of normalcy that comes after going through treatment. So I think it's really important for the storytelling, but then also helping to use their experience to inform what happens next. So researchers need to hear about the patient experience. We were just talking about shared decision-making. What better way to inform the healthcare community about what patients experience if those stories aren't being shared? So for us, it's absolutely critical that we have patients, survivors, family members, loved ones involved with us as we continue to hopefully help change the healthcare landscape for patients.
Yes, thank you. Thank you. So for all of those out there who, you know, have gone through, tap into Zero, to us two, to the Prostate Cancer Foundation, and look for ways that you could become, you know, active in mentoring and sharing your story and helping others that are going through your journey. And as Patrice said, in, you know, providing your feedback so that the healthcare community knows, you know, the long-term and sometimes even the short-term or individual effects of the recommendations that they made. Dr. Kelly, this is a question that's been asked quite a number of times. How reliable are DREs, or digital rectal exams, and PSA tests?
Well, they're a part of the diagnosis of prostate cancer. You know, and I think that, you know, it is not one, either a PSA or digital rectal exam that diagnoses prostate cancer. These patients coming with symptoms, you have to understand their symptoms, you have to understand the physical exam, you have to understand their PSA or other blood tests that may contribute to it. The other thing that's very important, a lot of people forget about, is the family history, all right? Is there family history, breast cancer, all right? Did your father have prostate cancer? What age? Those are very important things to also assess the risk of a patient. So I think that, you know, it's just not everybody gets a PSA and a digital rectal exam, that's it, because you will miss a good proportion of patients with prostate cancer.
Okay, thank you. Thank you for that. Howard, you know, as patients are looking for opportunities to be more educated, learn more, you know, we gave them these websites, and we'll add them to the follow-up for this program. What else can they be doing in terms of educating themselves? Is there a calendar of events that the various advocacy organizations do? Is there one thing or two things a year that you would say to them, do not miss, if you have any relationship with prostate cancer from a patient or survivor perspective?
We don't keep a calendar, although we're likely to have a large virtual scientific event this year that will be made available free of charge to anybody that wants to attend. It's called the Prostate Cancer Foundation Scientific Retreat. But in terms of receiving information about prostate cancer from the moment an internist said, you know, your PSA is a little elevated, I think you should see a urologist, all the way through, if hopefully never, but a lot of patients end up in the able care of the 3 medical oncologists and many other medical oncologists on this call. Our patient guide, which is free to download, is, I believe, you know, an A to Z very intensely physician vetted document, free to the world, that gives a lot of great information on what it means, what the risk factors are, maybe how to prevent it with diet and lifestyle, but more importantly, what questions to ask your doctors, and a lot of support opportunities, and that's on pcf.org.
Thank you. Okay, Chaz, I'm going to ask you a question from a woman's point of view. I hope I don't offend the men on the panel. I'm married to a man. I have two men, a 16 and a 6-year-old in my home. I'm the daughter of a man. My dad died when he was 60 of a massive heart attack. He was a cardiologist, ironically, never went to the doctor. My husband, who's 45, despises annual checkups. In fact, you know, when he was told, okay, this is going to be the one where we do the colon checkup, he was like, nope, I'm feeling fine, I'm not going. So, you know, big, bad, bulky Chaz, who has walked the walk, I want you to look in the camera and tell your brothers, get to the doctor, and this is the question that I want you to ask as it relates to prostate cancer. Go.
So here's the deal, fellas. With any diagnosis of any disease, it comes down to a couple of different things. Quality of life, number one, and do you plan on being here tomorrow? If you can answer those two questions honestly to yourself, don't ask your friend, don't ask your boys, don't ask your wife, don't ask your girlfriend, ask yourself, do you plan on being here tomorrow? That's number one. And if the answer is yes to that, then these are the things that you must do. Not that you should do, but you ought to do, that you must do, because this is your care. In our industry, in the fitness industry, we always talk about personal training. At the end of the day, the first word in personal training is personal.
Yes.
Your healthcare is personal. No matter how many of these fine experts, whatever information they share with you, the doctors, the nurses, the oncologists, the urologists, I've sat on different boards about this before I got diagnosed. It comes down to you personally as a man deciding that you're going to be the quote unquote proverbial, how we used to say in the old days, a man. That means you got to take action. That's what we do as men. One way or the other, we got to take action. So we got to take action for ourselves, and then we got to take action for our spouses. We got to take action for our girlfriends. We got to take action for our kids. I have 2 sons. They have to now be diagnosed at 35 because of what happened. Had I not been proactive, had I not done this, I may not be here. That's a fact. That's in the black and white on a sheet of paper. So I say to you again, what do you plan on doing tomorrow? You plan on being here? If you plan on being here tomorrow, you have 2 choices: live or die.
Yeah.
If you live, you have to live for yourself by advocating, getting tested, even if it sucks, and it does.
Yeah.
And just a quick little answer to your question. I'm going through treatment now from starting my radiation 5 years ago to help heal my insides from what happened to me. But I'm still alive. So it is scary. There is no doubt. There are fears, there are unanswered answers, as a doctor told me, and there are unanswered questions. But nothing happens if you take no action. So gentlemen, take action.
Yeah.
Just like you would if you're playing golf, just like you would if you're playing basketball with your boys, get after it. You will find out what you need to know. And it may not be that bad. Some of these doctors can attest to this. It may not be as bad as you think. Cancer is a scary word, man. I'm sorry. It's the worst word in the world to hear because it's that unseen. It's that unknown, much like COVID-19 has been for us during this pandemic. It's that unseen unknown we're not sure of. But I can tell you one thing for certain. If you do not take action, then action will be taken for you. I'd rather be the action giver than the action receiver.
Yeah, no, I love that. I think that's going to resonate with a lot of men. I love the picture of who you are, you know, the optic of who you are, because you're not the old white man. If we have the old white man on the you know, you sit there.
Don't offense to my white brothers out there.
No, it's true. You say, of course you have prostate cancer. I mean, I once worked with an oncology group where you know, I said, oh, it's so sad. I feel like all these grandpas are coming in and they're all being diagnosed with prostate cancer. And the oncologist I worked for at the time said to me, if you live long enough and you're a man, you're going to get prostate cancer. And then you start thinking that's what the takeaway is, that this is an old man's disease. So I feel like it's so incredible to have someone like you. And, you know, for the listening audience, if you're a patient, share your story. If you're a caregiver, talk to the people that you work with, and let them know that, you know, this starts at understanding your risk and then seeking out screening. So really, you know, tap into some of these patient advocacy organizations that can get you to the right resource. All right, well, we're running out of time, or we're getting to the end of time. I never do a town hall without trying to do something lighthearted at the end. This has been, I know this is going to be, I don't mean this to be a downer, but I mean this actually to kind of lift everybody up. Last night, 3 o'clock in the morning, my car was stolen out of my driveway. I felt so much like, what? How could this happen? This is like the timing of it, you know, everything else. And I thought to myself, I've been really focusing through this whole COVID-19 on the concept that joy is not circumstantial. So I thought to myself, you know, as 3 o'clock in the morning comes, 3:45, my husband comes home. He's a security guard. He comes home and he says to me, your car's not in the driveway, it was stolen. And I'm like, what? You know, how has this happened? As the day progressed, I signed on to Facebook and it said a memory from last year. And the memory was my now 6-year-old graduated from pre-K this day last year. And I remember just sitting there, almost the like dichotomy between how I was feeling about my car and then this big smile that came on my face and the memory of being with this little boy as he graduated from pre-K, and it was such a big deal. Joy is not circumstantial. Whether you are someone with a diagnosis that you're managing through now, whether you have your fears about COVID, you know, there's a joy that inhabits each one of us just as a natural state of being. And so to end this town hall, I'd like to just quickly go around the room and ask each one of you, what reminds you that joy is not circumstantial when things get tough? Vivek, I'm going to start with you.
Well, Sarah, I think similar to your story, I think I get joy out of my 2 sons who are actually sleeping in the room next door right now.
Beautiful. Beautiful. I love it. I love it. And we get to spend so much more time with them.
Exactly.
COVID. Kevin, I'll go to you next.
Yeah, I agree. You know, joy is from the family, but I also get a lot of joy just hearing the patients say thank you. You know, and I think, you know, we're people. We love people. We love to take care of our patients, and you know, that's what we're here for.
Yes, beautiful, beautiful. Patrice?
Yeah, well, it's a fantastic question. For me, the joy, I want to echo everyone, really comes from family, but seeing how even in the midst of everything that's happening, the family bond is how we strengthen each other and continue to move forward. And then seeing that ripple through the community, like seeing folks come together for food pantries and all of the things, just the way the country is uniting in many ways is very beautiful to see.
Yes, absolutely. Ian?
So you know, I certainly get joy from, you know, friends and family that I interact with and the colleagues that I work with. But, you know, I got to say right now, some of the joy that I experience is getting things done quickly and without all the fuss. And others on the panel, you know, mentioned that as well. And so there are, you know, things that we can do at work now in 48 hours that used to take weeks. And because everyone's focused, and you know, we're going to get to a new normal. And as someone else said during the panel, let's hope that part doesn't go away. I think it may have even used, Sarah.
Yes.
So let's not lose that ability to go beyond the rules and get things done well, but get them done fast.
Yes, thank you. Howard, what about you?
Well, finding new ways to stay close to friends and family and be supportive of a research enterprise numbering in the thousands. But as a favor to myself and in honor of Mr. Rodgers, I would say personal training by virtual means with my Equinox personal trainer. So there you go.
And you know, that's such a good, I want to take a second to say, it does help you to release so much, you know, just getting out. I know there's been times that I've been skipping, I'm working, and then it's like dinner time, and then it's get the kids ready and go to bedtime. And sometimes my husband will say, stop, let's go for a walk. And just being out in the air and just like getting your body moving, it really does change. So for, you know, anybody who's sitting there saying, you know, what's one small thing I can do? Take a 5-minute walk in the sunshine and just let it all come in. David, how about you? Joy is not circumstantial. What's giving you joy these days?
So I think it's certainly been an existential experience. My parents have been isolating in their retirement community in Australia now into their 8th week, and they just lifted the lockdown. So that's great. And they had not seen their most recent grandchild face to face. So now they've got to do that. And my wife and I were following this on WhatsApp, and we sort of looked at each other and said, you know, if they hadn't had the lockdown, we wouldn't have thought about this at all, because it would have just kind of happened. And the thing is that it's great because, you know, he's grown up immensely in the 2 months since he came into the world. But I think that it does focus on that. And the small teams experiences, whether it's family, the people you work with, the people you research with, or the broader experience we have with some international colleagues who, some of whom are actually not with us anymore. That's been the real ups and downs for me.
Mm-hmm. Thank you. Bo?
Thank you for saving me for last. Thank you all for being part of this. I'll go along with family. If you see the globe up above my head that was given to me by my daughters, Ray and Hannah, when I took my new office, and since my new office is home now, it's here with me. But the other part is, you can see I love books, and 2 that I want to particularly recommend to all of you out there. First is called Prostate Cancer Strikes, Navigating the Storm, and it's a 1-person support group as far as I'm concerned. It takes this man, Gog Scannon, and it follows him from finding out that his PSA was high all the way through his diagnosis, through treatment, and into survivorship and recovery. And I think that's wonderful. He talks about what he did wrong, what he wished he had done, those kinds of things, very helpful. The other is, we're all patients. This is called The Empowered Patient, and it's critical. You talked about shared decision-making. We use the term informed decision-making. It's ultimately your decision. And if you're not working with a doctor and a care team that understands that, find another team. You're living with all the decisions you make in terms of your life, in terms of your health, and so on. And I did partner with my 2 urologists, but some folks, it's not a partnership. And regardless of what it is, you need to be informed, you need to make the right decisions, and you need to take the time to do it. I'll end with an African quote, because this is all about being together. If you want to go fast, go alone. If you want to go far, go together. Nobody beats this disease alone. Go together with everyone who can support you.
That's so beautiful. Thank you, Bo. Well, thank you to all of you. I really have enjoyed this one. I feel like I know that I don't know everybody, but I feel like I know everybody. And so I want to kind of take that forward and just stay in touch as we continue to navigate through. I heard, you know, someone say that we're all going through the same storm, but we're all in different boats. And I do feel like that. I feel like everybody has unique situations, and we're all trying to just kind of figure it out, huddle together, and get through it. So I really appreciate that each one of you have given your time today. It matters. I say that every time. This matters. It matters to the many who watch, and it matters to the one that, you know, makes different decisions because they watched. I do want to give a shout out to Chaz's training. It's F as in Frank, 45training.com. Chaz, you have a client in me. I'm going to visit that myself because it does give home workouts. You know, guys, we got to stay moving. I looked at my iWatch and there were days where I had like 500 steps and I'm thinking, what? And it's true because my steps were from my office to my bathroom, to my kitchen, back to my office, to my bedroom. So we can't live like that. We've got to start getting out there, getting moving. I mean, that's part of the bigger picture. Thank you to all of you. I pray for all of you through this time. I pray for your organizations. I pray for your missions and your visions for the things that you're doing in your life. And I do look forward to the time where we can all be back together. For the doctors, I will be watching with you in solidarity this weekend for ASCO, this coming weekend for ASCO, for all the exciting things we'll be seeing. And Ian, thank you so much for sharing what you're doing on a global level, especially when it comes to COVID vaccine development. I think that that's something that we all have our eyes on. So thank you. Have a wonderful rest of your holiday weekend, and we'll see you on the other side.